vitals have to be checked, sir. And patients, we have to see whether the patient is getting oxygenated correctly, like oxygenation part is correct or not. Then through ABG, we can check whether the CO2 part is correct.
Any score that we can use?
Sir, HACOR score can be used, sir.
So the HACOR score is used for prognostication of patients on NIV. The 5 criteria that it uses are heart rate, acidemia, consciousness, oxygenation, and respiratory rate. If the rate is more than 5, then there is a high risk of NIV failure. Coordinator Abhishek, what are the indications for mechanical ventilation in the case of COPD exacerbation?
Sir, when the patient has altered consciousness, when there is a risk of massive aspiration, can be used in post cardiac arrest also, sir, in case of, and then when the NIV is not successful, sir, despite being on NIV, patient has features of failure, there is hypercapnia which is persistent, then we can go ahead with invasive mechanical ventilation.
Any need for vasopressors and inability to take out the secretions. Next.
My patient responded favorably to therapy and he was discharged on domiciliary long-term oxygen therapy and BiPAP. He was asked to follow up at respiratory OPD after 4 weeks for assessment.
Major Kesu, how will you follow up this case in the OPD? What is the frequency? After how many weeks will you call this patient? After you have treated him and discharged him?
So after 1 month.
1 to 4 weeks. The duration can be between 1 to 4 weeks. And what are the parameters that you are looking at in the OPD? What will you check? Sit. Dipankar?
Sir, we'll ask for the history first, whether he again had, is there any resolution of symptoms? Clinically, we'll look for respiratory rate, use of accessory muscle saturation. Then investigations, we can look, do an ABG and look for any persistent severe hypercapnia. And we can do pulmonary function test again to see if there is worsening of...
that is usually done at 3 months, after 12 weeks. Next. So basically, what we want to do is we want to confirm that the patient understands his medication. He is able to take it for, and that his technique is proper. That is able to take the medication, and this is the right time to institute some non-pharmacological therapies like pulmonary rehab, and the patient should be educated about his disease. Besides this, the comorbidities that the patient has should also be looked at this time, and at 12 weeks is the time, at 3 months is the time when we do a repeat spirometry. Next.
My patient came with a complete blood count, including AEC and ABG. He was made to undergo lung function tests like spirometry, body plethysmography, and DLCO, and 6-minute walk test. His investigations were essentially normal. However, his AEC was raised. It was 336 microliters per minute. His ABG pH was 7.37. PCO2 was 53 millimeters of mercury. PO2 was 54 millimeters of mercury, and bicarbs were 27 millimoles per liter. In his spirometry, it showed severe obstruction with significant post-bronchodilator reversibility.
Surgeon Lieutenant Colonel Behek, what is the role of spirometry in a case of stable COPD?
So we check for FEV1 timing, sir.
At diagnosis, what is the criteria for diagnosis?
So we see whether it is respiratory or obstructive, sir.
What is the criteria for diagnosing COPD?
Sir, FEV1 upon FEC less than 0.7, sir.
Post FEV1 by FEC, no? It has to be after bronchodilation. If it is less than the ratio is less than 0.7, then we can confidently say that. And with the history of exposure, that means the patient has COPD. What else? What other ways can we use spirometry? We can follow up the patient with spirometry to see the effect of medications, as well as we can grade the level of obstruction. Next.
In body plethysmography, it revealed hyperinflation with increased total lung capacity, and the RV by TLC ratio was increased also. In his DLCO, it has showed reduction with a proportional reduction of KCO. And in a 6-minute walk distance was 180 meters with significant exertional desaturation.
Surgeon Lieutenant Governor Shamsha, what are the goals of treatment in a stable COPD case?
So reducing the functional, so reducing the dyspnea of the patient, like symptomatic benefits, sir, first, and reducing the mortality benefits, sir, and improving the functional volume, sir, like improving the lung volume, sir.
Okay, said. We are basically looking at two things: whether the patient has a high symptom burden or whether the patient has a high exacerbation burden. So the patient will either fit into one of these two tracks, or the patient may be having both high exacerbations as well as high burden of symptoms. So, we treat the patient for reducing symptoms, which includes relief in symptoms along with increased exercise tolerance and a rise in health status. While reducing the risk includes, we have to prevent disease progression, as in progression of the disease, and we also prevent and treat exacerbations and reduce mortality. So basically, we are doing it to reduce symptoms or reduce the risk. The Major Prakhar. What are the ETO types of COPD?
Chronic bronchitis or
ठीक है, ठीक. School leader Abhishek.
So based on etiology, it can be first is COPD G, sir, which is COPD genetic, which is related to deficiency of alpha-1 antitrypsin C. Then is COPD D, sir, which is related to development, which can be because of low birth weight and premature delivery, sir. It can be COPD C, which can be because of exposure to cigarettes and tobacco exposure, and COPD P, which is related to biomass exposure. Then there is a COPD I, which is related to infections like tuberculosis or chronic infections can be present. HIV can also be manifested. Then there is COPD associated with asthma and COPD U, which is undefined, sir. We don't have the etiology.
Right. So these are the various, as he has already told, these are the various ETO types of COPD. Coordinator Kruti. What is the follow-up pharmacological management? As I've already told, there are two tracks. One is symptom reduction and one is risk reduction.
Sir, depending, the gold gives gold A, B, and E, sir. So depending on the MMRC being 0 to 1 or the CAT score being less than 10, it can be A with the less exacerbations, less than 2 per year or less than 1 hospitalization per year, sir.
Group A has less exacerbation as well as a low burden of symptoms. So what does Group B have?
Group B has more symptoms, sir, MMRC 2 or above or CAT score of 10 and above with less exacerbations, sir. Group E has exacerbations irrespective of symptom burden, sir. 2 exacerbations per year or 1 requiring hospitalization. So if the patient fits in Group A, then he will require only bronchodilator therapy, sir. Group B will be double LABA plus LAMA therapy. Group C, we will assess the requirement for inhaled corticosteroids, sir. Like in this case, patient had AEC of more than 300, sir. And increased exacerbations, we'll add that.
ठीक. So if the track is of symptom reduction, that means the dyspnea is prominent, then we give either LABA or LAMA. If the patient does not improve, then we can go to LABA plus LAMA. That means long-acting beta agonist and long-acting muscarinic antagonists. And if this is also not helping, then we can change the device or change the molecule. Or we should also be adding on the non-pharmacological therapy like pulmonary rehab. NC-pentane is a new drug which can be added, and we should also investigate the patient for other comorbidities. While if the patient is having recurrent exacerbations, then we start with LABA or LAMA. But if the patient continues to have symptoms and the eosinophils are, the AEC is more than 300, so then we can start the patient on, we can add on ICS also. That means the patient will be on ICS plus LABA plus LAMA. But if the patient is on LABA and LAMA and the eosinophils are low, then we can add both LABA and LAMA. And if the patient still does not improve, then we can think of adding roflumilast or azithromycin. Next. Next. These groups, we have already discussed these groups. So the group E is the group of concern where the exacerbations are more. In this group, inhaled steroids should be given. Next. Dr. Sweta, we have already discussed part of this. When should inhaled steroids be given in COPD? What is the subset of patients?
So patients who have inflammation and moderate amount of exacerbations, to reduce inflammation, we have to give steroids.
Patients who are prone to exacerbations. How many exacerbations?
More than 2 exacerbations.
2 moderate or one severe requiring admission. Okay. Besides exacerbation, what else do we look at?
The eosinophil count of the patient, so if it's more than
More than 300. And if there is an overlapping asthma also, then the patient will benefit with steroids. What about patients who have a AEC of between 100 and 300?
So we can also try and non-inflammatory things like roflumilast in those patients.
In less than 100, we go for roflumilast or azithromycin. If it is between 100 and 300, so we can switch. We can try LABA and LAMA. If that does not work, we can add ICS in this also. So basically, the response to the inhaled steroids is basically a spectrum. Below 100, it usually does not work. Above 100, it usually works, and above 300 is are the patients who should be given ICS. You will find a lot of patients who are already on some bronchodilators from somewhere. So somebody is taking a Seroflow or a Foracort, and then you do a spirometry and you diagnose that patient to have a COPD. So how do you change this management? How do you deal with the ICS LABA thing? Dr. Firdos? If the patient is well controlled and not having exacerbations, or the patient is having multiple exacerbations, what do you do?
In exacerbation, we can give short-acting beta-2 agonist, sir.
How do you change the therapy? What do you do with the ICS LABA? ठीक है बैठी. Shamsha?
So if the patient is already asymptomatic and the patient is already on ICS LABA and the patient is having symptomatic relief, then the patient can continue the same treatment, sir. And if the patient is not having symptomatic relief, then we may consider adding LAMA, sir. A dual therapy or a triple therapy, sir.
So if the patient is currently not having any exacerbations and the symptom burden is low, we can continue with ICS LABA. If the symptom burden is high, so we should consider ICS plus LABA plus LAMA. If there is no previous exacerbation history, then the patient can be controlled with a LABA and a LAMA. And if the patient continues to have exacerbations, then also we should switch to ICS plus LABA plus LAMA. Next. This is a newer drug which has been added to the algorithm. It basically is a phosphodiesterase inhibitor, and it is an anti-inflammatory and a bronchodilator, and it leads to decreased dyspnea and better lung function. Next. Dipankar, any role for biologics in COPD?
Sir, if he's having recurrent, very frequent exacerbations.
Yeah. Patients who are not controlled with ICS plus LAMA and having frequent exacerbations, the subgroup that we usually look at are the ones who have high eosinophilia. Next. So the 2 drugs that have shown some promise include dupilumab and mepolizumab, which have both shown a reduction in mortality, but in a very select subset of patients. Next.